Welcome to the Society for Technology and Engineering and Innovation in Neurosurgery. My name is Dr. Christopher Honey, and with me I have...
I'm Kai Miller. I'm a neurosurgeon at Mayo Clinic.
I'm Bryan Klassen. I'm a movement disorders neurologist at Mayo Clinic.
This thing we're calling the STEIN Fireside Chats. What's its origin?
Well, what STEIN is it was when I was a resident about a decade ago, we had this idea to basically to get functional neurosurgeons who are the geeks of neurosurgery together, just to spend time together at the national meetings. And I would create these custom Steins, and when I was a resident, they would charge people $10 to show up, and everyone got a commemorative Stein and would bring it home. It's now in its 10th year, and in the past 6 years I've been at Mayo Clinic working with Dr. Bryan Klassen, and we just spend a lot of time thinking about neuroscience, thinking about neuromodulation, and spending time together talking about interesting things. And we had this idea that a lot of the things that we do, we give talks at conferences about them, but it might be nice to take each of the different lectures that we have and lectures that our friends have around the country and put them up in one place, but have conversations surrounding them. And so we came up with this idea of STEIN Fireside Chats.
And we think it'll be a useful tool for trainees in neurology and neurosurgery, but we also just mostly, we're thinking it'd be fun.
Yeah.
Yeah.
So that was the reasoning behind it. The location that we're at is the world headquarters of STEIN. It's a pub at an undisclosed location in Rochester, Minnesota.
I have a question just to start out, which is, what is a functional neurosurgeon? What are the other neurosurgeons, the ones that don't do anything functional?
Okay, well, I should say this isn't necessarily, even though neurosurgery is in the original name, it's not a neurosurgeon thing as so much as a neurologist, a neurosurgeon, neuroscientist kind of a thing. A functional neurosurgeon, so I'm a functional neurosurgeon and also a pediatric neurosurgeon. Functional neurosurgeons deal, loosely speaking, with disorders of brain circuitry, although there's also distributed nervous system circuitry, so for example, people who have pain get peripheral stimulators. But a lot of, if you hear about deep brain stimulation, treating movement disorders like we treat, or in epilepsy, these are all diseases of circuitry. And functional neurosurgeons it's a specialty within neurosurgery where we focus on circuitry. So, I happen to specialize primarily in epilepsy, and movement disorders, but pain is a very large part of functional neurosurgery, and increasingly neuromodulation for a variety of other indications, things like psychiatric disorders, trying to create recovery devices after brain injury and following stroke or trauma. And we have a large initiative here at Mayo to develop this.
So, Dr. Klassen, am I right to remember that you have a background in computer science? And how does that play into your role as a neurologist?
Yeah, well, I think part of it, we were talking a little earlier about how even as a kid, I learned programming from my brother on the Apple II Plus series of computers. And I think just kind of thinking along those lines and getting into programming in high school and then learning about it in college, I guess it really set me up for a logical thinking process. And that is part of why I went into neurology. My father was a physician and I went into medicine, but he's a rheumatologist, and it seems like there's a lot of ambiguity in those diseases. And I thought, well, boy, neurology is a system now that's almost designed like a computer. We have these hierarchies, as we were talking about. You can think about memory in a computer. You have the register, which holds things immediately, and then it goes to this form of memory and that form of memory. And so it's part of why I went into neurology, is I guess what I'm trying to say. And then only later did I learn that actually neurology, when a patient comes to you with a neurology problem, it's really pretty ambiguous a lot of the time. So it's not quite as straightforward as I thought. But I think it's helped me think logically, and it helped me kind of acquire my neurologic knowledge and how to approach the idea of where is the problem in this particular case. And then over time, it's been a tool that I've been able to use for research, to some degree for clinical practice, but for research along now with Dr. Miller, where we're looking at these brain signals. We typically are using custom algorithms for the way that we're analyzing these. And another thing that I do in addition to the intraoperative neurophysiology is movement neurophysiology in general. So a lot of this is in the outpatient setting. We'll use surface EMG, accelerometry, and so I've been able to use my programming skills to, build analyses for those sorts of studies that we do clinically as well.
And so what makes your team different from other neurologist, neurosurgeon teams? What's distinctive about your team?
Other than just the fact that we're infinitely better than, Mike Oken and Kelly Foote at Florida, they've got nothing on us.
Yeah.
Well, no, I think we are geeks for the electrophysiology, so we record a lot of data, and the data that we record is incidental. So we record during our DBS surgeries, we record during some of the epilepsy monitoring periods, and we spend time having fun, kind of hanging out together, analyzing data. So I don't know, I guess we're small picture scientists, you know what I mean? Like we like tinkering with the recordings that we have from different settings, and trying to come up with something that'll help individual patients, I think and we like hanging out with each other, I think, that helps,
But, if STEIN is about engineering and innovation, would it be fair to say that you try to do a kind of work that is more innovative?
Well, so we do have, we do have scientific findings that have come out. We have devices that we're working on for the types of surgeries that we do. And then we also have devices that we're working on for neuromodulation. And that's as part of a bigger team. So, STEIN in general is sort of hopefully it'll be like a larger, well, not, it will be, it is a larger community, but hopefully this series of lectures and episodes will bring in lots of folks from around the country, like Kelly Foote and Mike Oken from Florida, who are, well known for being not as good as we are, and learning from them and trying to integrate it into our practice, but really building a community.
Actually, I do have a question about that.
Yeah.
So how does innovation spread, right? So suppose that you develop a technology or technique, or your colleagues at Florida develop a technique. How is it that it moves to be adopted by other surgeons? Is there some kind of formal process, or is it more informal?
Well, I have some good examples of this. Actually, the meeting for these STEIN events. I don't know why I keep coming back to. He's a stellar surgeon, probably is why. But this guy Kelly Foote, I meet with him and we have a drink or two, and we're always just talking about the details of surgery. So how do you put your incisions on the scalp, right? These things sound like, well, that's not very innovative. That's the kind of thing people are thinking about a couple hundred years ago. But there are informal ways that we spread small innovations, right? And then there are formal ways like publications that we read from each other. But a lot of the smallest innovations, at least in neurosurgery and probably in neurology as well.
I think the equivalent for us would be as we're programming the devices, different techniques, different approaches that we'll learn from each other as we interact in conferences and other settings, would be kind of the equivalent of that. These small changes that are all now big, kind of big innovations and larger changes in practice. In medical practice, a little different than in science, because we're all bounded by a lot of regulatory structure around it. So to really push something through to clinical practice requires a lot of that work, as well as just the science behind it.
Yeah. And the other thing I think is, in the medical world compared with the scientific world, you can check your ego at the door, right? Like, I'm probably one of the most, we've known each other for 20 years, I'm probably one of the most arrogant scientists, right, literally. But as a surgeon, at the end of the day, it's not about you, it's about these patients that you have, right? And so the innovations that you have there, the whole goal is to do something that's going to help somebody. And so the way that things progress is twofold. There's the formal setting, and then the informal setting really does carry through. We have conversations about things. If I have a particularly difficult patient where I'm worried about let's say, stimulating one target or another, or I think this person has a different presentation. First thing I do is I get on the phone or either text my colleagues or call them and find out if they've had that situation before. What do you do about it? And trying to synthesize that knowledge it's not always done, right? And the hope is that we can continue to do this, and maybe we can get some of these things online so that, you know, trainees and other surgeons have easy access to it. And then hopefully people can come in and tell us about their, let's say there's a technological innovation. I'd really like to have people here to talk about a new closed loop system they may have built. Maybe we'll have folks from industry. You know, one of my biggest heroes is someone from industry, Martha Morell, the founder of NeuroPace. This was a neurologist who in the early 90s had this idea that you could record brain information, decode it online when people were having a seizure, and then stimulate to shut it down. And over a more than 30-year arc, she took this from an idea into something that was tested, something that was implemented in a device, and now we treat patients with all the time. So it's not, you know, the idea would actually be to interact with industry as well. So each new innovation, as it were, or each new engineering breakthrough, it's important for us to learn about them and talk about them and hopefully integrate them into the way we take care of patients.
So there's these three different kinds of ways that I'm hearing about information spreading. One way is publishing papers.
Sure. Yeah.
Another way is talking to people at conferences or just on the phone as needed, kind of an informal social network. And then this third way is essentially via industry in some sense through these kind of trials and developments of technologies, right? How influential is each of these three channels in terms of, like, you know, if you compare your practice today versus, you know, a decade ago, let's say, which of these have you learned the most from, or, you know, which of these have made the biggest difference to how you are as a practitioner today from what you were a decade ago?
Yeah, that's a good question. Well, let's take something like the rechargeable battery, right? So it was a situation where there was one of the companies had a pretty good rechargeable battery, and I thought, well, it was just available with one company and not with another. And I thought, well, for my patients, if they can have a rechargeable battery, you know, every time you put in, let's say, a DBS system, you got about 5% risk of infection. If I use a rechargeable battery, they're having less surgery, less likelihood for infection. That's something that it's simply a tool that industry gives us access to. But, you know, things like countersinking your hardware into the bone, I mean, there may be industry innovations.
What is countersinking?
Well, for the case of countersinking into the bone, you have hardware, and if you're putting in deep brain stimulation electrodes here and here, you can, if you just put it in with the commercial locking mechanisms come in place, there'll be little bumps that are up there. And you can avoid having those bumps by drilling down the outer part of the skull and getting it so it's flush.
I see.
And the term countersinking just comes from people when they would put screws and so forth into wood, they would make it so that the screws sat below the level of the wood. Yeah, so, and that came, you know, that wasn't an industry thing. It was driven by a number of surgeons, including Kelly Foote.
And when you heard about it, was it through word of mouth, or was it that surgeons were actually writing it? Because they're kind of like a, you know, best practices in neurology or best practices in neurosurgery kind of.
For that example, a guy I did my fellowship with, Casey Halpern, he had learned it from another surgeon. He said, well, let's do this. So we started doing it, and then I kept it in my own practice, and that's how we do it.
Is it the same in neurology? It sounds like what I'm hearing is that a lot of your day-to-day practice is mostly dependent on direct kind of mentorship and your kind of network of fellow clinicians. And it's less the case that reading journal articles in your field has impacted your practice.
Well, I guess it depends. When you think about deep brain stimulation and programming and the parameter space being, you know, so wide, and in each individual patient, the leads may be in a slightly different place. It's very different than, say, treating Parkinson's disease or other neurologic diseases medically, where if you give them a certain dose of this medication, you can do that in 100 people and really study the same intervention. Every time you do deep brain stimulation in a patient, it's actually a different intervention. And so I think in that space where you sort of have a unique situation with that patient, learning the tricks of the trade and learning these little these little ideas for what to do if a patient has, you know, you can stimulate a patient with Parkinson's, which is a disorder of too slow of movement basically, and you can have them get dyskinesia, excessive movement from it. And so there's ways that people have change the stimulation parameter to sort of attenuate that. And so knowing how people have done that, and then ultimately as enough people do that, there'll be a paper that comes out about it. But these papers about this sort of thing are really typically smaller groups of patients. It's not like a hypertension study where they're looking at 10,000 patients on this specific medicine and what happens. So I do think that even though it's important to kind of know what the literature is saying, I do think in that area we still get a lot by just peer-to-peer communication.
So that's in a way part of what this podcast series is designed to accelerate.
Yeah, hopefully it'll democratize the word of mouth, and we can set out the little things that we've learned, but also bring people in who have insights where we would normally get them, over a coffee at a conference, but instead, we get them over coffee at a conference and then have it out in the public through this series. Yeah. Well, thank you.
Thank you.
Yeah. Well, hopefully it's the start of something great. Yeah.